taken steps to help everyone stay at home, keep food on the table, keep their jobs, and to help businesses stay afloat. And to date, we have made available over $2.2 billion to support Indigenous families, students, businesses, and communities and organizations during these unprecedented times. And let me assure you, our support will continue as long as COVID-19 is still a threat. No one will be left behind. At this time of year, we are also concerned about influenza. We can reduce the spread of seasonal flu by following the same practices as with COVID-19. We also know that the uptake for the flu vaccine is lower among Indigenous peoples than in non-Indigenous communities, in part due to the issues that I mentioned. The H1N1 vaccine in Indigenous communities was extremely challenging. This points to a pattern that we must avoid at all costs as we get, if and when we get to the deployment of a COVID-19 vaccine. We must take steps to ensure that everyone living in Canada can access future treatment and vaccines. It includes real and deep engagement with communities, nursing stations, and those who hold the health portfolio within their community. Our country's recovering from the pandemic will take time. We must continue to be careful and listen to the advice of our public health experts. Miigwech, Nakumik, Marcy Cho, thank you, merci à tous.
First of all, I want to acknowledge that we are on the unceded territories of the Algonquin people. There have been 768 First Nations community cases in Canada, an increase of 32 cases from the day before. This compares to over 173,000 cases in the general Canadian population, which was an increase of 1,800 cases in a single 24-hour period in Canada. The First Nations Unreserved case rate is 1/3 that of the general Canadian population. 632 First Nations community cases have recovered. 123 are still active, compared to over 17,000 cases in the general Canadian population still active. 61 cases have ever been hospitalized with COVID, and there have been 13 fatalities in First Nations communities, compared to 9,541 fatalities in the general Canadian population, a case fatality rate that's 3 times that of the First Nations communities.
Je vais répéter les informations de Dr. Wong en français.
I will be repeating Dr. Wong's information in French. So we reported 768 laboratory confirmed cases in First Nations communities, 32 more than the day before. As comparison, 173,000 cases were reported in the Canadian population at large, which represents an increase of 1,800 cases in 24 hours. The case of reported cases in First Nations communities is 1/3 of that across the Canadian population. 632 people were infected in First Nations communities, and those cases were resolved. Or rather, 632 cases have been resolved. 123 remain active. 61 people were already hospitalized because of COVID-19. There were 13 deaths as compared to 9,541 in the general population, which represents a mortality rate 3 times that of First Nations communities. Thank you.
Nous allons maintenant ouvrir les lignes téléphoniques.
We will now open the phone lines for questions. We may have one question.
One question, one follow-up. Operator, over to you.
Thank you. Merci. Please press star 1 at this time if you have a question. S'il vous plaît, appuyez sur étoile 1 maintenant pour poser une question. And our first question, la première question est de Kirsty Kirkup from Globe and Mail. Please go ahead. La parole est à vous.
Hello, good afternoon. Thanks for taking our question. Just on the issue of systemic racism, Minister, specifically Maurice Sinclair has said that federal government is dropping the ball in terms of intervening, that, quote, the federal government has a considerable economic club here they are refusing to use to assist people of color, the most vulnerable people in Canada, to be treated more humanely. Why not look at stipulating in the federal health transfer agreements that systemic racism is not acceptable given these are provincial healthcare systems, funded by the federal government that are administering these systems.
Thank you, Kirsty. I think if there's any conclusion to the three reports that I mentioned, the Vien report, the inquiry into murdered and missing Indigenous women, and the calls to action, and the final report that I quoted as part of the words I gave today, is that I think we've all dropped the ball for too long. The speech from the throne feels like ages ago, but it was only a little more than a week or so ago, mentioned explicitly that we need to move on Indigenous and distinctions-based health legislation. That socioeconomic gap that exists and has recently been reiterated, even though the United Nations report shows a closing of the gap between Indigenous and non-Indigenous peoples, shows the drivers to, in about 50% of the cases, to be health-based and health-driven. There is an immense amount of work to do, and there is an immense amount of responsibility that lies on the federal government's shoulders. There is without question a jurisdictional challenge as we move, and we haven't done so, to ensure that Indigenous peoples get first-class health care across Canada. That includes off-reserve being where the federal government has primary responsibility to deliver. I think since everyone is still reeling from the death of Joyce Echaquan, I have difficulty underlining the investments that the government has made since 2015, but they have been significant. But clearly more needs to be done. More needs to be done more quickly. That is what our experience from the first wave of COVID has shown us, and it includes a reform of the healthcare system that is culturally sensitive. So that work can't be dictated from Ottawa. It has to be dictated to us by Indigenous peoples. And if you look at the various numbered treaties, there are different views as to what that constitutes in terms of healthcare, and we can't ignore those voices. And so when we move to a relationship that is off-reserve and more in urban areas, that's work that we need to do with the provincial government. I think provincial governments have recognized that they need to get going as well. But we see the effects of COVID accentuating some of the challenges that we face, whether it is the elimination of harm reduction models in the West, in Alberta specifically, whether we look at the disproportionate impact of the opioid crisis on Indigenous peoples, where more people have died of opioid overdoses than of COVID. I think it's quite obvious to anyone that pays any amount of time to this issue that work needs to be done now, faster. Even though those promises have been made in the past, they need to be done faster and quicker, because people are dying.
Christy, did you have
And
a
just as
follow-up?
Yeah, thank you very much. Just to follow up, I know you said the details of this urgent meeting on systemic racism will be forthcoming, but can you give us any sense of how soon the meeting will be called, and what would be your response to people who might think, this is a meeting where people will be talking about what has been documented in the reports that you pointed to today, including the MMIWG report as well as the TRC's calls to action?
Detail in the next few hours or day. We hope, as I said, it's urgent. So as early as the end of next week. There are challenges, obviously, with physical meetings. It'll be a virtual meeting, and space will be made for those who are experiencing the racism and those who are working in the healthcare area. Those people are more than familiar with what is in the reports, and so the focus will be on that sharing and objectives to be set forth with timelines in the relatively short term. But I will have more information on that forthcoming shortly.
Thank you. Next question, prochaine question.
The next question, la prochaine question est de Jamie Pasha-Gumskun from APTN. Please go ahead. Your line is open.
Hi, thank you. Please let me know if you have a problem hearing me. So the financial supports, you mentioned $2.2 billion so far. Now I'm wondering, are those financial supports that were put in place in the first wave, are they still holding? Because now we're into the second wave, and is there plans for more support financially?
Oh, thank you, Jamie. I think it would be helpful if we provided you with a full list of those supports. It includes, it's multifaceted. There are obviously 2 rounds of Indigenous community support funding that totals close to $700 million. Those that went pretty much directly into communities. The second wave of that has currently been deployed. The second wave of that funding has been slightly modified to frankly, to respect the advocacy that we heard, that the funding be a little more targeted where there is need. That doesn't equate with actual cases or spread of COVID. So we are attempting at the same time to be as flexible as possible. We are, to answer your question directly, that is not the end of it, no, and we are looking for additional amounts of funding. But the amounts that I quoted include the surge capacity funding that we have at Indigenous Services Canada. It includes several $100 million in business supports, obviously tailored to the Indigenous reality of business and Indigenous businesses. So working through their institutions, Aboriginal financial institutions, more specifically, as well as dealing with the Indigenous tourism industry. When you talk about business supports and being sensitive to band-owned businesses. They were tailored. They are over and above the supports that were announced for Canadians, particularly when we talk about the CERB or the employment support, because we know that those needs are different and more nuanced. But it is by no ends, and we're at pains to repeat this, that is not by no ends the end of the conversation, because we don't know how COVID will continue to impact Indigenous communities. And as I said in my remarks, sadly, we have to conclude that the second wave will hit Indigenous communities harder than the first wave, and we will be mobilizing resources in respecting community wishes to ensure that they have the resources necessary to hold up to the second wave.
Jamie, do you have a follow-up?
Yes, thank you. So like you mentioned, in light of a second wave, cases are on the rise all over the country in Indigenous communities. I'm wondering if you have a breakdown on rise per province, and is there an area in particular that concerns you?
I'm at the point where everything concerns me, Jamie, but there is a resource available on Indigenous Services website. It is we have a map that gets updated relatively regularly on a weekly basis, in addition to our weekly releases, and that gives us a breakdown per province, as well as some nuances, obviously, because as everyone knows, Indigenous Services Canada's primary responsibility is First Nations Inuit Health Branch, as well as primary health care on reserve. It affects our ability to execute and to gather data. So that data reflects in part data given to us by partners and territories, as well as FNHA in British Columbia. So there is some nuance to that data, but we'd be more than glad to provide that for you. And Tom and Val, I don't know if you have more to add, but anything you need in terms of data, we're glad to provide.
With this virus, we have to take it very seriously because we see an alarming rise in the recent weeks. We have to actually remember that this virus, is very clever. It attacks all communities. It finds a place to actually get into the community. So no place across the country is spared. I think that, if we don't take this seriously, this virus will run ahead of us. We want to run ahead of the virus. Thanks.
Perhaps I can just add, in terms of your question around, are there areas of the country, in terms of the active cases that Dr. Wong and myself mentioned of 123 that are currently active. The majority of those cases are in Alberta, Manitoba, and British Columbia at the moment.
Thank you. We'll take one more question from the phone and then turn to questions from the room. On va prendre une autre question du téléphone, puis ensuite on va prendre des questions de la salle. Operator, you can go ahead. Yeah.
Thank you. So the next question, la prochaine question est de Dylan Robertson from Winnipeg Free Press. Please go ahead. La parole est à vous.
Good afternoon to you three. I wanted to talk a bit about the rapid test quota. I know that PSPC does bulk orders and then negotiates with the provinces, and I was wondering if FNIB or ISC are just another party at the table there, or if there's a percentage of rapid tests and other sorts of equipment on a quota basis that gets diverted to your department.
Well, I think I'll let Val or Tom answer that, but I'd say as a preface, Dylan, the Gene Expert machines are a very sophisticated, very reliable machine that we've been deployed. They are rapid. There's close to 70 of them deployed in rural and remote communities, either in Indigenous communities or very close to them, to be able to do that rapid testing. Jamie had mentioned earlier the preoccupations that we have with respect to communities. Obviously, the rural and remote ones where there is a spread requires a significant amount of logistics and a massive deployment that on a per positive case basis would be much different than in an urban setting. And so that is a particular concern when we go through the three things that are most important to stamping out COVID, which is tracking, testing, tracking, and isolating. The Gene Expert machine that is deployed is key to that, and a key tool to ensuring that you get rapid results so that we can track the people that may have been in contact with a positive case, and so you're not isolating large numbers. We've seen that strategy work, and it's a result of that we want to continue deploying these rapid tests, as well as the more novel ones that have been approved recently. And Indigenous Services Canada, obviously, you have to look at the framework for distribution of these resources from an ethical perspective, focusing on vulnerable communities. So when it comes to Indigenous communities, we are absolutely more than just someone at the table. We have demands, and those demands get met.
Thank you very much, Dylan, for your excellent question. Regarding Gene Expert, for example, Canada has deployed 67 devices with close to 15,000 test cartridges, to areas in the north, where we facilitate the access, to rapid point-of-care tests. Of course, it's not just one department. We are supporting Public Health Agency of Canada in order to roll out, these point-of-care test kits, whether it's Gene Expert, or Abbott ID Now, or other, newly approved test kits. And again, the focus is on making sure that the North is not forgotten. The remote, isolated communities get access, to rapid testing. And already, there's been acquisition and procurement of these, new devices and new cartridges, to come into Canada. Thanks.
Thanks. And Minister Miller, I was going to ask you a bit about this initiative on discrimination. Indigenous leaders in Manitoba have said that the real answer to getting around the discrimination is health transformation, that you're not going to solve this issue unless it's First Nations and Métis controlling their own health care. I'm just wondering how this initiative interacts with that, and if you have any fear that this initiative will draw energy away from that devolution process.
Draw energy away from what, Dylan? Sorry.
From a devolution process, from a health transformation process, like if we're focusing so much on discrimination in provincial systems, does that take energy away from handing healthcare into Indigenous hands?
I think it's part of the equation. I think we know, and it's demonstrable that when Indigenous people have control over their healthcare system, the outcomes are better than when they don't. That is measurable. Part of that is a bit of a, obviously that two-pronged process that I had mentioned earlier, which is the focus of the primary jurisdiction of ISK on reserve, and then working with partners to ensure that there is a culturally appropriate healthcare system that treats or affords Indigenous peoples first-class care, which hasn't been afforded, and quite the contrary previously. If anything we've learned from COVID is that when we trust our partners and when resources are allocated based on that work that we do together with those partners, the results that are tangible with respect to the first wave demonstrate the ability of communities to deal with pandemic, which is fundamentally a health issue, and that works in communities that have their own hospital, that have control over their own the health portfolio. The results are incontrovertible, and part of reforming Indigenous Services Canada is not simply appropriations of more monies, but also the way in which we engage. And I think that has also been key to how Indigenous communities have reacted so well. The communities that I named in my speech do not have the same resources as non-Indigenous communities, yet they have had better results in stamping out COVID. So I think that's something that needs to be celebrated and not taken for granted. But there is much work that remains to be done in that transformation. Dealing with racism is a multi-pronged, complex problem. Recognizing it is one step, but that isn't sufficient. As an elected official, you have to keep moving forward and keep addressing it and keep reforming the system. So I know my answer was long, but it is a long road, and it is a long process. It goes through and necessarily through self-determination in healthcare, and that may be one of the things that is told to us as we engage on reforming Indigenous healthcare.
Thanks, Dylan. We'll now take questions from the room. Est-ce qu'on a des questions ici dans la salle? Oui. Go ahead.
Stephanie Levitz from the Canadian Press. I'm not sure if my question is better answered by Minister Miller or the doctor. Can you flesh out, given what you've said about sort of the rate of COVID infection in Indigenous communities being less than the rate in the general population, what is it specifically then that makes you think the second wave is going to hit so much harder than the first?
We have the numbers. They're trending. We have the largest number of active cases that we've seen. Of course, we're testing more, and so there's that aspect. But when we start to see those trends in active cases, we know that is occurring. Now, we're comparing different variables right now. I said it would hit harder Indigenous populations than it did. That Indigenous peoples will be hit harder by the second wave than they were the first. The first wave numbers are no one death is one death too many, but the rates were very low as compared to the non-Indigenous population. The second wave may very well hit the rest of Canada harder than the first. I just know the numbers that I'm seeing with respect to Indigenous peoples, and we will be close and 50. Once we get to 900, people have already been hit harder, and so it's just an unavoidable fact. Tom, do you want to?
Then as a follow-up then on the question of systemic racism, you alluded earlier to challenges that have existed in the past in terms of flu vaccine take-up and others in Indigenous populations. And I wonder if you can reflect on that in the context of systemic racism within the healthcare system, and if that is what is holding people back from accessing the care they need because they are afraid to go into the hospitals to get it.
Look, this is documented in the reports that I cited previously. People just don't want to show up. I think one of the things I felt a lot of gut-wrenching things this week, but one thing that hit me harder than I expected was some words that were shared to me by Regional Chief Ghislain Picard when he said that people, they normalize the situation. They just expect to be treated like garbage when they go in. I don't know why that is. I don't know why that bothers me so much. It's just accepting the status quo that's totally unacceptable is just it's revolting. the testimonial that all of us have heard in recent weeks and that is embodied in report is shocking. Indigenous peoples aren't surprised by what happened this week. They're disgusted, but they're not surprised because it's happened before. I think Canadians are. It was on video, obviously, so everyone to see. But I think people are shocked by the fact that this is a situation, and all instances of racism are unacceptable when you're at your most vulnerable. So too when it comes to interactions with police forces and excessive use of force, because people are at their most vulnerable. But why the hell would I go get a flu vaccine if I was going to get treated like garbage? You wouldn't. You just say, I'm not going to do it. There's also been, horrible instances of testing on Indigenous peoples in the past. And so that skepticism, we're not talking about anti-vaxxers. We're talking about people that have been treated terribly by what should be a first-class system in this country. And so their fear of the system is legitimate. When you give them control over the system, they trust the people that are serving them. We have a challenge, and Val and Tom have it as well, of convincing when we get a COVID vaccine, we have to deploy it in a culturally sensitive way to people that don't want it. One, are entitled to get it as soon as everyone else gets it, perhaps sooner given vulnerabilities. But two, don't want to feel like guinea pigs at the same time because their grandfathers and grandmothers were in some cases have stories of being tested on. It's all there. That is an additional hurdle that we all have to deal with when we deploy a vaccine. Assuming all the logistical work is seamless, there is still that hurdle that is very real, and we're not in the realm of conspiracy theories. This is real, legitimate fear towards a healthcare system that continues to fail them.
And when you actually look at an example of BC First Nations Health Authority, where the services, are provided by First Nations for First Nations in a most culturally safe way, and you see some of the successes in how they deal with all the different epidemics of various sorts. So something like that is something for all of us to actually.
Olivia, do you want to go ahead?
Yeah, thank you. Olivia Stefanovich, CBC News. Minister Miller, you had the chance to meet with the relatives of Joyce Echaquan recently. I'm wondering if you can tell us what kind of impression that left on you and what, if any, role the federal government can play in the provincial inquiry into her death.
We, the family, my good friend Jennifer Brazo reached out from, she works at the Friendship Center in Joliet, reached out to me and asked, informed me that the family was coming up with some band counselors, and Jamie from APTN was invited to document it. It was immensely courageous of the family to want to meet with Minister Bennett and me because they're a family in mourning. We didn't necessarily want to break their mourning period by inserting ourselves into a situation, so we wanted it to be as informal as possible, and obviously respecting that this is a family in grief, a man who has lost his wife and has to raise his kids alone, 7 of them. So the intention, there was no structure to it. The intention was to meet them and to listen and to be with them in their grief. Very difficult because we had to respect the COVID self-distancing challenges, which are very difficult during emotional periods because you want to be with people and support them as best you can. So we met a beautiful family that told us about their grief, and I consider what they did to be exceedingly courageous because, they want justice, and I'm glad the Quebec government moved quickly on inquiries to get to the bottom of this. But foremost, they want justice for every victim of racism, which, difficult to formulate that when you're grieving for your family. The reason, and I mentioned earlier that this is a responsibility that is shared provincially and federally, but the reason the focus has been on Quebec, the people of Manawan and Joyce Echaquan's family are feeling with respect to the refusal to acknowledge systemic racism. It's deeply wounding for them. It doesn't mean the focus won't be on the federal government. Indeed, we had a discussion with councillors about the needs within the communities, education and housing. It was an opportunity to speak about that. Again, courageous, because they are speaking about their people and their needs while they are very much grieving the loss of their mother and wife. And the community member and one of the sons got down on their knees. And, you look at these videos, you feel like Carolyn and I should have gotten down on one knee and begged them for forgiveness for a system that failed them. And that's what I remember from this meeting. But you can have these meetings, but I think people want action, and the federal government will take action. We'll support the provincial government where needed, and move on our areas of responsibility as well. There is a challenge jurisdictionally in reforming a system that is so that has been, frankly, a source of tension. We talk about transfer payments constantly, but the work that needs to be done primarily in community is one of getting more resources and devolved in the proper way, and then reforming the way Indigenous peoples are treated in off reserve. It's a misnomer, but across Canada, Indigenous peoples need first-class health care, and they haven't been afforded it up to now.
Yeah, to follow up, just 2 points here. I'm wondering if you can tell us how exactly the new legislation, distinctions-based legislation, health legislation, and the mental health strategy will help to address systemic racism in the healthcare system. And I'm wondering what else specifically the federal government can do to address this problem. For example, MIWG and TRC reports have been getting cultural competency training to healthcare workers. So could the government consider putting a condition on these healthcare dollars to see this sort of training among the provinces?
Well, I think the lesson to be done, deployed in the proper way, we need to support provinces in their reform. They need to be as committed as we are to changing things, and it is their responsibility in part. It is also our responsibility to ensure it gets done. We can spend hours on jurisdictional tangles, but it won't make people's lives better. It won't save lives. The reform of the system will ensure that people, when they go into a healthcare institution, are treated like everyone else, and therefore stay alive, or they feel like they can go into the institution themselves, or it is run by one of their own. There are many facets to this. What we need to recognize is the federal government may have some answers. There are in reports, but the process to getting distinctions-based health legislation requires co-drafting and an immense amount of consultation, and in some cases recognitions of rights that haven't been perfected or recognized in a long time, if ever. When I guess for all of us that work in Indigenous issues, perhaps as a reflex, as a politician, you're expected to have all the answers. I don't have all the answers. Indigenous communities have the answers. We just haven't been listening. That's a difficult realization, because it sounds like you're justifying immobilism, but you're not. It's a process that needs to be respected, and the outcome will be that those gaps that are measured by the United Nations will be closed if we do this the right way.
We'll take one last question from the room.
Hi, Mackenzie Gray with CTV News. Mr. Miller and Dr. Wong, these are for you. Just want to pick up on what you were saying earlier, Mr. Miller, about the vaccine and the kind of historical issues that Indigenous Canadians have faced in terms of issues surrounding treatment that they might have received previously, and a reticence that they may have to get a vaccine. I know I've asked you about this previously, but you mentioned in your answer here that there might be kind of a public health need to get a vaccine to them first, considering congregate settings, poor living conditions, and remote areas where there's not an ability to get healthcare quickly. Is that the plan for Indigenous Services Canada, to deploy a vaccine to Indigenous communities when it becomes available sooner because of these issues? And if that is the case, how do you kind of combat the issues that many Indigenous people feel about healthcare in this country?
Mackenzie, I think these are, and I'll ask Val perhaps to answer in part because we are actively working on and I'll characterize it as an ethical framework and how to deal with the deployment of the vaccine. Canada has procured options on a number of, in the suite of range of vaccines. We still don't know their efficacy or their reliability for that matter. But it is obvious that when it comes to deploying the vaccine, some care has to be taken into who gets it first, in what way they get it, and then alluding to the issues that we raised earlier about legitimate skepticism towards the healthcare system. There is a lot of groundwork that needs to be laid in order for communities to feel empowered, and choice is front and center there. The experience with H1N1 deployment was absolutely challenging, and so we do have experience from how vaccines were deployed. Then we're looking at now perhaps the largest deployment of vaccine in world history. So it comes with a lot of the questions that you're posing now. These are questions we're working on currently to address. To say we have a complete approach would be wrong at this point, but we are aware of the issues and we are aware of the challenges of getting them into communities, even assuming all the logistical issues are resolved, and they are not small, given the remoteness and all the issues we've talked about today. So Val, do you want to add on that?
To it. So absolutely, we're connected to the National Advisory Committee on Immunization, and we are working with the Public Health Agency leadership, and will continue to do so with respect to the vaccine. But the vaccine itself will be distributed through provincial territorial health systems. So we, at some times, depending on if we have a physical presence in the communities in terms of nurses, frontline providers, may administer the vaccine and actually run immunization campaigns in the communities, but the vaccine distribution system will be through provinces and territories. We will work with partners also to customize the communication campaigns to make sure that the language and the visuals, that it is provided in Indigenous languages, all that adaptation comes forward. But I do have to say that in the partnership discussions that we have had, there's a lot of receptivity to, let's have this vaccine in our communities. We want to immunize people in the communities. We've not heard a tremendous amount of resistance or concern on that front by the leadership. I think they will be champions to ensure that their community members will be protected by having strong immunization campaigns. And during H1N1, overall, the immunization rate was actually higher in First Nation communities than the mainstream population. The challenges were relating to the distribution system, which sometimes is more decentralized in some provinces. So this time around, we want to ensure that the prioritization framework is clear, that it's been worked through with First Nations, Inuit, and Métis, and that they are very strong partners in terms of the distribution and the immunization itself.
Second question is about testing. Dr. Tam has mentioned regularly that these rapid tests and the antigen tests, even going back to the Spartan Bioscience testing that was many months ago, these kind of tests would be sent to Indigenous communities and it would be prioritized as such. Is there a need in these communities at this point in time for more tests like there is in the rest of Canada? And two, has there been a set number of the ABID tests, either the antigen or the point of care tests that have been recently approved that is being set aside for Indigenous communities and that will be sent there?
I think on your last point, I think we'd have to verify it to make sure that whether that is the case. The gene expert tests that we have been deployed are exceedingly rapid and proven testing and have a very good track record. They have been used previously to test for TB in the far north in Inuit Nunangat. So they are one of the key tools in the three pillars of ensuring COVID gets stamped out. There is a strategy to testing. It is sometimes not prudent to do an entire community. It just gives you a snapshot in time. We aim towards a certain percentage of positivity to ensure we're actually hitting the mark, given you don't want to overcharge the healthcare system in the lab system. So there is a strategy that gets deployed and a bit of a science to it, obviously. There's always been a knee-jerk reaction that everyone can sort of test in the morning and go to work. COVID doesn't work that way. There is a proper protocol to be followed with these tests. The rapidity obviously eliminates the headache of staying home for 14 days waiting for a test, which is totally unacceptable. But people need to understand that this is only part of one tool, as a part of a multi-pronged strategy to eradicate COVID. I don't know if you remember the bit of a saga we had with the Spartan test, which in case of Indigenous communities created a sense of false hope that they would come immediately, and it turned out not to be a level of reliability where they could be sanctioned for that level of use. So we also want to be able to, when we promise something, deliver on it. And as to your main point on allocate, obviously there'll be an allocation for Indigenous communities for their own testing, and working with the nursing stations and the health portfolio managers to make sure that everyone gets what they're entitled to.
Public Health Agency of Canada is working very hard together with us and communities in order to try to move as many of the available test kits, to remote areas, including the provision of training of providers in remote areas, say in a clinic, so that the community themselves can actually do the tests and get the result the same hour. And all of that is prioritized by Public Health Agency together with us in order to make sure that we bring the access, of these, test kits to the north. As an example, recently, with the outbreak, in Manitoba, in Little Grand River, the rapid response team rapidly mobilized, gene expert, point of care, testing devices and test cartridges, and offer to the community tremendously helpful to be able to test a large number, offer the test, and get the results, right away in the community, helping to actually stop the outbreak. So, thanks.
Thanks, Mackenzie. On va prendre une dernière question du téléphone. We'll take one more question from the phone.
Thank you. Merci. The next question, la prochaine question est de Patrick Foucault de Radio-Canada, Manitoba. Please go ahead. La parole est à vous.
Thank you very much. Hello, Mr. Miller. Patrick Foucault, Radio-Canada in Winnipeg. The number of cases in the Indigenous reserves in Manitoba has nearly doubled last week. Went from about 20 cases, and now we're talking about 50 in this province. At what point will you be concerned by the Manitoba situation, and what will you do to address the issue? Answer. It's an excellent question. To update you as to York Factory, the situation is stable and under control. With respect to the situation in the community of Little Grand River, or Rapids rather, we are optimistic. We feel we are in constant contact with the community, and I wish to emphasize the exceptional work that was done by the rapid response teams for pandemics in Manitoba. They are doing truly exceptional work. They're a first-class team in the way that they respond. The public health protocols that were observed in response to the situation in Manitoba. During the first wave, of course, Manitoba did a wonderful job with respect to dealing with positive cases on reserve. There may have been a handful, and even that might be an exaggeration. So they really responded very well and quickly, and it worked. So we're continuing to interact with them. I spoke to Chief Farland Dumas to follow up on the situation and see what resources may be required. And with respect to more remote communities that are harder to access, there's a more intensive mobilization in case of positive cases. There are more vulnerabilities, of course, in such communities. Sometimes you need mobile structures to isolate people who have tested positive or who may find themselves in overly crowded housing. And that's an unacceptable situation, but we have to deal with it to eradicate COVID. With respect to the two communities of interest, for now, we feel positive despite the most recent outbreak.
Vous avez une question de suite?
Did you have a follow-up question?
Merci.
No, thank you.
Merci. Ceci met fin à la conférence de presse. Thank you. This concludes today's press conference.